Good evening, one and all. Today we are here for another session of Skip 10, okay, which is taken by Dr. Srikanth, who is the professor and head of the Department of Oral and Maxillofacial Surgery at Manipal College of Dental Sciences. So we are honored, Dr. Srikanth, to have you on our platform, on Skip session 10. So I hope
thank you, Dr. Bentley.
Yeah, I hope it will definitely be an exciting session for all of our students, the third BDS students and the final BDS students. So with these few words, I wholeheartedly welcome Dr. Srikanth, my batchmate also, and a renowned surgeon to this Skip session 10. Next, I welcome my colleague, Dr. Rino Rubak-Suman, who is the reader in my department and who is the main backbone of this particular program. Dr. Rino also, I wholeheartedly welcome you to Skip session 10. Next, I welcome our students, our third BDS students and the final BDS part 1 students to this Skip session 10. Okay, so now I hand over the mic to our student coordinator, Sandra, for introducing the speaker of the day.
Dr. Srikanth Ji is a professor and HOD in the Department of Oral and Maxillofacial Surgery, Manipal College of Dental Sciences. He completed his BDS degree from Vinayaka Mission Shankaracharya Dental College in Salem. He did his master's in Oral and Maxillofacial Surgery from Manipal College of Dental Sciences. He has a total of 51 publications in his name. He has a 13-year of teaching experience and is currently professor and HOD of Manipal College of Dental Sciences. He has undertaken various research activities along with Information and Communication Department, MIT, and Department of Biochemistry, KMC Manipal. He has been awarded Fellowship of Indian Board of Oral and Maxillofacial Surgery and AOCMF Fellowship at Ludwig Maximilians Universität Klinikum, Munich. We are honored to have you today as our speaker, sir.
Thank you.
Yes, Dr. Srikanth, you can start up. Yeah.
I can share the screen.
Yeah. Yes, screen is visible.
Screen is visible, right? Okay. Good evening, one and all. Thank you, Bentley, for giving this opportunity to have a discussion and webinar along with your students. I'll be taking this topic, odontogenic space infection. I know most of you will be knowing the theoretical part. So I'm going to cover a small portion of the theory, then followed by various case scenarios, which we have experienced here in Manipal. So the learning objectives will be how we classify head and neck facial spaces, the spread of infections, how it happens, and various principles of management, and how we diagnose this various facial infections and the complications associated with the same. The concept of the facial space is based on the anatomist knowledge. Until fascia are separated, they really do exist. By pus or blood, they get separated even by surgeons' fingers. Okay. So the facial spaces, broadly, they are mainly covered with the fascia, which can be divided into superficial fascia and the deep cervical fascia. The superficial fascia is nothing but just a layer of dense connective tissue that courses deep to the subcutaneous tissue. So the superficial fascia just covers the subcutaneous tissue. The subcutaneous space is very closely associated with this fascia, that is directly just underneath the skin. So coming to the deep cervical fascia, which has its place mainly in the neck and also around some portion of the face, especially around the parotid gland and also on the temporalis muscle. So the anterior layer is also called as investing fascia of the deep cervical fascia. It is mainly divided into parotidomesenteric and temporal. The middle layer, the main portion is the pretracheal or prelaryngeal part, that is the visceral division. Even the carotid sheath also exists in the middle layer. And the posterior layer, as you can see in this diagrammatic presentation, it is mainly covering the vertebrae. Okay, so the danger space is also comes under the posterior layer. Okay, so you can see the carotid sheath that comes in the middle layer, which is also called as Lincoln's highway. Various classification schemes are there for the facial spaces. As we all know, they're mainly classified as primary and secondary spaces. Primary spaces mainly related to the maxilla and mandible, and the secondary spaces, which mainly includes the masticatory spaces and other deep neck spaces. So according to the other classification, Papazians, they are classified as supraoid and infraoid group of spaces, and also spaces of the total neck, that is deep spaces, include retropharyngeal and spaces of the carotid sheath and danger space. Can you hear me?
Yes, yes.
Yeah, sorry. The numbers, there is other classification given by Gordonsky's and Holekes, that is a numbering classification. Okay, by numerical numbers. That is space 1 is nothing but the fascia, superficial fascia, that is subcutaneous space. And space 2 is the space that is middle layer, which covers the main cervical strap muscles, as you can see in this cross section. And space 3 is the visceral division, that is again middle portion, which includes mainly the carotid sheath. As it is clearly evident, it is also called as Lincoln's highway. Highway, that means it connects from the mediastinum to the base of the skull. Okay, there will be an ascending or descending way of infection from this space. The space lying between the alar and the prevertebral division is the danger space. A danger space, again, as I said, the infection can spread to the posterior mediastinum or to the meninges. Then we have a space number 5, prevertebral space. So this is a numbered classification. Now coming to the spread of infection, the infection can easily spread along the muscles according to the attachment of the muscles through the tissue spaces and planes. That is the main mode of spread for the head and neck infection. Although it can rarely spread through the blood, so it results in septicemia, the meningitis, or it goes to the mediastinum and it goes into the blood. It can be a bacteremia or septicemia or lymphatic system. So as I said, along the tissue planes, the main things which determine is the muscle attachment. The primary spaces, that is buccal space, which is more common for the both maxilla and mandible, the buccinator muscle will determine. Whereas in the mandible, the space going to the deeper neck, like submandibular or other primary spaces, the myloid muscle, as you can see in this image. Okay. So in the case of maxillary teeth, infection, whether it comes out to the buccal side or to the vestibule or to the palatal side, it mainly depends on the, again, buccinator muscle attachment. If the root angulation is more towards the palate, it goes towards the as palatal abscess, more commonly seen in relation to the lateral incisor, maxillary lateral incisor. So infection from the molars, if the infection spreads to the root apex, if it goes beyond the muscle attachment, that is the penetration of the bone is below the myloid muscle, it goes into the submandibular space. If it is above the attachment, it goes to the sublingual space, as you can see in this. The same way on the buccal side, the buccinator muscle will determine, as I said, it can be vestibular or it goes below the buccinator attachment, it comes to the buccal space. So another important aspect is spread of infection from the third molars, which is very common because of the pericornitis or oral hygiene maintenance, and is very commonly associated with the infection spread to even to the deeper planes. So infection can spread on either ways, that is into the secondary spaces directly into the pterygomandibular space, as you can see in this cross section, or to the buccally or laterally to the submesenteric space, from where it can go to the superficial or deep temporal spaces. Either ways, it can go to the sublingual or the submandibular space, as you can see in this coronal sections. So depending on the severity of the infection, and the severity of the space infections, especially odontogenic, are mainly determined in relation to the deeper neck spaces involved, that is in aspect to the airway and the vital structures. So normal vestibular buccal spaces or a superior lapses are low severity because they cause minimal obstruction to the airway. Whereas moderately severity that is mainly seen along the masticatory space infections like submesenteric pterygomandibular space and other spaces. They hinder access to the airway, means that might cause a trismus restricted in mouth opening, or some amount like in pterygomandibular space, uvula will be pushed. So there is a chance for rupture and aspiration. So we need to do fiber optic intubation in them. So they hinder access to the airway. High severity, these are mainly the deep neck spaces, which are direct threat to the airway or vital structure, like carotid sheath. If there is carotid sheath involvement, there might be bleeding from the nose and mouth. That is also called as Herald bleeds, which very rarely seen, or sometimes goes to the danger space or retropharyngeal space, from where it can descend down to the mediastinum or ascend superiorly to the meninges or through the base of the skull. Now, coming to the principles of management, there are certain principles which are very, very important whenever we treat the odontogenic infections or the maxillofacial infections. Most important is to determine the severity. That just now we discussed the low severity or the medium severity or the high, very severe severity. Or we need to next is to evaluate the state of the patient's host defense, whether they are compromised host defenses, or any uncontrolled diabetic metabolic diseases like poorly controlled diabetes, alcoholism, or malnutrition present, or any other immunosuppressive drugs they are on. And we also need to determine whether the patient to be treated by a general dentist or by a maxillofacial surgeon, or with the ENT surgeon. So there are certain criteria where we need to refer the patient to a higher center or to the maxillofacial surgeon, is mainly when there is a difficulty in breathing and swallowing. These are the main indications. Refer the patient. So next point is to whether to treat infection surgically. It's always better to treat and must treat surgically. That is, incision and drainage is the best treatment modality, along with the empirical antibiotic therapy. And we need to also evaluate the patient frequently, because if once incision and drainage and antibiotic therapy, if the patient doesn't improve, then he might deteriorate very soon. So we need to go into that culture and sensitivity of the antibiotics which we use, and it is very, very important in this treatment aspect. That is one of the most important principle in treating the odontogenic infection, that is culture and sensitivity. So there are various group of antibiotics, narrow spectrum, broad spectrum. We always start with the narrow spectrum antibiotics, but whenever deeper neck spaces are involved, it is always better to give IV antibiotics and also a broad spectrum antibiotic therapy. So we have something called as empirical antibiotic therapy. That is triple antibiotic therapy. It is mainly based on whether all the spectrum of microorganisms are covered or not. Gram-positive, aerobic, mainly it covered by augmentin. Anaerobic microorganisms, mainly by the metronidazole or clindamycin, or the other group of microorganisms, gram-negative, in a deeper neck spaces, that is mainly covered by aminoglycosides like gentamicin, amic acid. Okay, so whenever we have a space infection, if it is odontogenic, a simple empirical antibiotic therapy is enough. But whenever neck spaces or masticatory spaces are involved, we need to start with this triple antibiotic therapy. Coming to the surgical drainage and incision, how we judge that the pus is formed or not, and the purpose of the surgical drainage and incision, and what are various principles which we drain. I'm going to go through this. As we all know that it goes through the 3 stages: inoculation, cellulitis, and abscess. So normally abscess has a duration of more than 5 days. It is fluctuant and it is reddened. So normally we can diagnose it by ultrasound simply, and it always contains dead cells. It is very fluctuant. It can be easily drained. Whereas cellulitis, it is more diffuse, okay, and it is more painful also. Sometimes it becomes very life-threatening, as in examples of Ludwig's angina. The main purpose of incision and drainage is to rid of all the toxic purulent material, and also to increase the oxygenation of the infected tissue, so that by better perfusion of the blood, which contains antibiotics and defensive elements. So you need to always place the incision in the aesthetically acceptable area, and you dissect bluntly. The very favorite question that is very commonly known is the IND technique is Hilton's method of drainage. So whenever you insert the sinus forceps, it is always parallel to the vital structures. And always we need to secure a drain and stabilize it with sutures. So you can see in this image, sinus forceps and drains are placed. There are various types of drains, which I will be showing in the clinical scenarios right now. You can see here corrugated rubber drain, okay, or a plastic drain, and also a flattened, it's also called as Jackson's drain with multiple perforations. They are very efficient drains which will have dependent drainage. We can have a flow outwards and inwards also. And the sinus forceps is a atraumatic instrument which is used parallel to the vital structures to drain the abscess. So before going to the various scenarios, when we diagnose with something with pain, swelling, or an odontogenic infection, we need to take few radiographic evaluations. So basically a screening radiograph and OPG or IOPAs. So if we have any severity of the airway compromise or masticatory spaces or deeper neck spaces is involved, then we go ahead with a CT scan. So we need to evaluate the severity and evaluate the host defense mechanism. Accordingly, we need to decide whether to refer to a higher center or a maxillofacial surgeon. If it has to be done as an outpatient therapy, that is in the initial stage, that can be an inoculation stage, just a dental abscess or a cellulitis, which is localized. Okay. We can remove the cause. Most important step is to remove the cause, that is extraction or access opening endodontic treatment, followed by oral antibiotics therapy and supportive care. If it is a cellulitis or abscess stage, incision and drainage is mandatory. When there is an abscess, you will find pus. But when there is cellulitis, it is only, there is no pus, only serous fluid will be there. But however, cellulitis also in few particular scenarios, we need to do IND, that is to cause decompression. Okay, so the spread of infection is limited. If it is a failure to improve even after 2 to 3 days of simple incision and drainage and antibiotic, it is always better to refer to an higher center or a maxillofacial surgeon. Going to the maxillary spaces, we have infraorbital space. I'm going to just brush through them. So we know the boundaries. It is present just below the eye, and the main muscle which determines here it is levator angularis and chordatus labis superioris muscle. So most common clinical finding is obliteration of the nasolabial fold. This infection has a peculiar complication that infection from this area can go to the cavernous sinus thrombosis through inferior and superior ophthalmic veins, which are present in this space. As you can see in this picture, so high chances that thrombophlebitis of this angular vein can lead to cavernous sinus thrombosis. So we need to be very, very careful when we have such kind of infections. And also very close to the infraorbital space, we have, as you can see in this image, danger area of the face. That is nothing but the philtrum ala and the upper lip region. So infections from there can easily spread to the meninges. Management is mainly by incision and drainage. As we can see in this image, the various sites where intraoral incisions can be given. The canine space or the infraorbital space, vestibular incision is usually given, and it also has dependent drainage along with the empirical antibiotic therapy. You can see in this child, he had a premolar tooth, a 12-year-old male patient. He had a premolar infected tooth which was ignored even though access opening was done. So the infection has spread to the canine space or the infraorbital space. However, it has not reached to the orbit. Okay, so it is localized. So we need to do incision and drainage because the child was not allowing to do it under local anesthesia. We had taken it under GA. And you can see that pus drainage and also a drain tube which is placed intraorally in the vestibular region. So coming to the buccal space, so it is common for both maxilla and mandible. The muscle which determines is the buccinator muscle, which is on the medial side, as you can see in this image. Laterally, you have your skin and subcutaneous tissue. This space is connected posteriorly to the submesenteric area, the submesenteric space. The various neighboring spaces, as I said, to pterygomandibular space also medially it gets connected. The swelling is typically present below the zygomatic arch and above the inferior border of the mandible, and from the oral commissure to the anterior border of the masseter, as you can see in this clinical image. So you can see the amount of pus which is easily draining out from this buccal space, and you can see various drains which are usually placed into the area so that we can irrigate and do wound debridement regularly. Okay, so the buccal space, the incision can be placed at the most dependent area if it is extraorally coming towards the inferior border of the mandible, as you can see in this image. Or otherwise, if it is towards the maxillary teeth which are getting involved in the maxillary vestibule also, we can open. But if the buccal space is typically involving only that area which is not cross the lower border of the mandible, then we need to place an incision exactly across the occlusal plane. Okay, as you can see in this image, you have upper and lower teeth, the occlusal plane in the center area, so that we can have drainage of the buccal space. Okay. Now comes the infratemporal space. As you can see in this image, there are various boundaries. The infratemporal space is very closely associated with the masticatory space, spaces infection, that is superiorly, it connects to the superficial temporal space or the deep temporal space, and inferiorly to the pterygomandibular space. There are various anatomical landmarks. The most important significance of this space infection is, even though it is not a masticatory space, as it is closely associated, these patients will have various complications, and most important is trismus. Patient will have severe restricted mouth opening. As the content of the the content of this infratemporal space or the retrozygomatic space, most important is pterygoid venous plexus and maxillary artery and various other vessels. The pterygoid venous plexus can get connected to the cavernous sinus thrombosis, okay, which might result in thrombosis of the cavernous sinus. So you can see in this 39-year-old male patient who came to our OPD with severe restricted mouth opening. Okay, this patient has, as you can see in the CT images also, he has an infratemporal space and also the buccal space. Okay, you can see the fat stranding and hyperdensity areas in this coronal CT, and also see the temporal region. That is also edematous. Okay, this patient we have posted and drained it through incision and drainage, all multiple spaces, which I will be showing the images. But however, we had to take this patient a second time because he later developed a meningitis also. Few signs of meningitis like neck rigidity were present after 5 days. And even the culture and sensitivity also showed that most of the antibiotics, he became resistant. Okay, the empirical antibiotic therapy which we gave, they have become resistant, and we started with higher antibiotics based on the culture and sensitivity, that is meropenem, and few antibiotics which cross the blood-brain barrier. Now coming to the superficial temporal space, as you can see, it is superficially, it's located to the lateral surface of the temporal bone. You can see in this clinical image, a typical dumbbell-shaped or very typical swelling in the relation to the temporal space. Okay, a shiny swelling. This is also an odontogenic infection because of the upper second molar on the left side. And you can see the collection in the coronal CT, okay, with air spaces, air pockets, which are clearly visible. We had to drain it through extraoral and also intraoral. Typically for the scenarios where we need to drain, for the infratemporal or temporal spaces, we can drain intraorally. That is, we can place the incision at the maxillary vestibular region. Even though patient has a restricted mouth opening, we can drain this temporal or infratemporal space by maxillary vestibular incision. It is also called as Kruger's incision. Okay, Kruger's incision, as you can see in this animated picture image. Okay, and we need to place, and most advantage of this incision intraorally is that it will have dependent drainage. Okay, the other incision is usually placed, you can see in this image, see the pus draining from the temporal region directly in the same patient, okay, who had a dumbbell-shaped swelling. See, that's typical characteristic feature for the retrozygomatic or the temporal space infection. So you see this various corrugated and Jackson's drain, which I have shown. This patient had both temporal and all spaces, even including buccal space, submandibular space, and also some amount of tissue got necrosed, especially in the submandibular area. So all the spaces are drained and antibiotics are given according to the culture and sensitivity, and patient recovered with time. Coming to the mandibular spaces, the primary mandibular spaces are mainly the buccal, sublingual, and submandibular spaces. So sublingual space, as we discussed previously, the myloid muscle will determine whether the infection will go to the submandibular or sublingual. So anterior teeth or the premolar teeth, more commonly it goes to the sublingual space. And you can see that the characteristic feature in the sublingual space is the elevation of the tongue, or the floor of the mouth gets elevated, which might cause difficulty in swallowing and sometimes respiratory difficulty. The infection from there can easily spread to the submandibular space or to the deeper spaces also. Okay. So the incision is placed usually intraorally. It can be drained, but it will not have dependent drainage. Do remember that. We need to perforate the myloid muscle for having dependent drainage if it is done extraorally. And also the incision, when we place in the sublingual or the floor of the mouth, we need to be careful about the ducts and also the sublingual veins. There can be spontaneous bleeding. Submental space and other space which is present in the anterior region of the mandible. Okay, the infection for this is mainly from the lower anterior teeth. It doesn't contain any much vital structures, only the anterior jugular vein or the lymph nodes. The clinical significance is the swelling is present mainly in the chin, just beneath it. We need to place an extraoral incision for that, just under the chin. Okay, we need to incise through the platysma muscle, and it has to go through the natural skin crease. Now coming to the submandibular space, the typical anatomical boundaries, anteriorly it is bounded by the anterior belly of the digastric and posteriorly by the posterior belly of digastric. It has, so superiorly by the inferior border of mandible and inferiorly by the digastric tendon. So the contents mainly includes the submandibular gland, facial artery, lingual nerve are the major structures. So molar teeth, if they get involved, there are high chances that submandibular space infection will occur if the infection penetrates below the myloid muscle. So you can see the incision. The best treatment for this is these patients will not have trismus, okay? But because of the guarding pain, that patient might not open the mouth, okay? So submandibular space is not a masticatory space, so they very rarely have trismus, okay? We can have a good mouth opening by just doing mouth opening exercises. Okay, and you can see in this image, multiple drains are placed in the submandibular region bilaterally. This is a case of Ludwig's angina, okay, which bilateral submandibular space and sublingual and submandibular spaces are involved. This patient was in third trimester when she came to us with a submandibular space along with the buccal space. So we always know that all the treatments are to be done only in the second trimester, if any. But in relation to the space infections, especially odontogenic, it is very, very important to treat the pregnant patient at the earliest, either by root canal treatment or extraction, incision and drainage, either local anesthesia or general anesthesia. We must never delay. So this patient we have treated immediately under general anesthesia after OBG consultation, and we had to drain by extraoral approach. You can see in this the amount of pus, around 100 ml of pus has drained out. If we ignore, I will going to discuss one case scenario which we got it published also, like in a third trimester in the 7th month, which the patient ignored, which resulted in Ludwig's angina in the coming slides. Okay. So clinical significance of this space infection, that from the submandibular space, it can easily spread to the deeper spaces, to the lateral pharyngeal space, from there to the retropharyngeal space. And if bilateral spaces are involved, we call it as Ludwig's angina. Okay. Now coming to the masticatory spaces, we have various masticatory spaces, as you can see, submesenteric, pterygomandibular, infratemporal, and temporal spaces. This diagrammatic representation is very a good one, which you can clearly differentiate various spaces, and it's very easy to draw also. You have a cross section, vertical cross section or a coronal cross section of the mandible. So on the medial side, you have your pterygomandibular space. On laterally, you have your submesenteric space, infratemporal space superiorly, and temporal space. So you can see that. So you can see the submesenteric space. The typical feature for this submesenteric space, you can see clinically also that in this space will result a typical clinical feature of trismus, severe trismus. And there is no raise in the earlobe. When the earlobe is raised, we can differentiate it from the parotid abscess. Okay. So typically the boundaries for the submesenteric space, anteriorly it extends up to the anterior border of masseter, posteriorly to the posterior border of masseter. Inferiorly, you can see that swelling is extending till the lower border of the mandible, and superiorly up to the zygomatic, lower border of the zygomatic arch. Okay. Now, pterygomandibular space, you can see in this image, medial to the mandible, you have a lot of collection of the pus, okay, as seen as air spaces also. Typical presentation, again, trismus, severe restricted mouth opening. But in this kind of scenarios, there is rarely that space infection is present externally. Okay, the swelling will not be present externally. It is more intraoral and medially, and which results in difficulty in swallowing, and also uvula gets pushed medially. Okay. The main contents is the inferior alveolar nerve, and also a small portion of the lingual nerve which runs through that, and myloid nerve. So infection from this can happen because of the contaminated needle injection or the pericornitis related to the mandibular third molar. Okay, and sometimes middle ear infections can also lead to pterygomandibular space. So the typical incision which is given along the anterior border of the mandible, one incision through which we can drain all the masticatory spaces is Seacher's incision. As you can see this image, you can give an incision along the anterior border of the mandible and insert your sinus forceps medially, you will drain pterygomandibular space. If you insert laterally, you will drain submesenteric, and if you go superiorly, the infratemporal and temporal spaces, you can drain it. Okay. And if it is extraoral nix, we will see in the next coming images. You can place it along the angle of the mandible, as you can see in this image. So coming to the various case scenarios, we had a 9-year-old child who came following extraction in a dental clinic, and antibiotics were given, a plain amox, and the patient never taken the antibiotic for more than 2 days after the extraction. So after 3 to 4 days after the extraction, patient visited along with the parents. She had severe trismus. Okay. So as for the principles, we need to send it for culture and sensitivity. Okay, so it has come as methicillin resistant Staph aureus. So culture and sensitivity has a very wide role so that we can deliver correct antibiotic therapy and treatment. So we had to post this patient under GA, incision and drainage. You can see in this axial and coronal CT, see the masticatory spaces, how clearly they are involved. Pterygomandibular space on the medial side of the mandible and the submesenteric space, typical to the clinical presentation. See around that, okay, the air spaces, density is flat, fat herniating into it. And you can see the pus draining intraorally, as just we now discussed Seacher's incision, which is placed along the anterior border of the mandible. The pus draining out from there. See around 100 ml of pus has been drained in this child. And after that, mouth opening has improved a lot, but prolonged antibiotic therapy was required for almost 12 days for this child. And this mouth opening is after 7 to 8 days. So as we discussed previously, Ludwig's angina in pregnancy, which required premature delivery. We had this 29-year-old female patient coming to the casualty with severe respiratory difficulty.